In this video, we illustrate coil embolization and parent artery occlusion of a dissecting aneurysm. Dissecting aneurysms of distal intracranial branches can often be safely treated with endovascular occlusion of the aneurysm and the parent artery. Often no distal infarct occurs in this situation because of the presence of an effective leptomeningeal collateral network. A 55-year-old woman experienced a thunderclap headache and presented to the emergency department, where CT imaging was performed and demonstrated subarachnoid hemorrhage in the interhemispheric fissure. CTA showed a small aneurysm at the origin of an anterior medial frontal branch of the A2 segment of the ACA. Catheter angiography confirmed a small aneurysm in an atypical location. The atypical location, fusiform shape, and presence of perianeurysmal stenosis all are features suggestive of a ruptured dissecting aneurysm. Given the anterior frontal location and the most likely presence of leptomeningeal collaterals, endovascular parent artery sacrifice along with coil occlusion of the aneurysm was performed. In this specific case, because of the silent anatomical location, we did not feel that further testing was required. Alternatively, when considering similar treatment in eloquent areas, clinical assessment during a balloon test occlusion of the proximal target vasculature of an awake patient, or radiological assessment during temporary target vessel proximal occlusion and injection of potential collaterals of an anesthetized patient are both valid methods to predict the risk of distal infarcts after a permanent parent vessel occlusion. Access to the common femoral artery was obtained. A 6 French guide catheter was introduced over the 0.035 glide wire, and the system was navigated into the distal internal carotid artery. A duo microcatheter was then carefully advanced over the Synchro 2 micro guide wire into the small aneurysm of the anterior medial frontal branch of the A2 segment via the right anterior cerebral artery. The tip of the microcatheter was placed into the sac of the aneurysm, and 2 small detachable coils were used to embolize the aneurysm and the proximal parent artery. Post-embolization right common carotid artery cranial injection demonstrated no visualization of the aneurysm or the parent vessel. MRI after 24 hours showed 2 very small DWI hits in other territory most likely related to the endovascular procedures, but no infarction or ischemia in the territory fed by the sacrificed branch. The patient was discharged on post-op day 2 on aspirin with no neurological deficit and resolution of the thunderclap headache. 6-week follow-up right internal carotid artery cerebral angiogram demonstrates occlusion of the right anteromedial frontal branch and no filling of the aneurysm. There is some reconstitution of the distal territory of the occluded branch by adjacent anterior cerebral artery branches. This case illustrates the principle that sacrifice of distal branches can often be safely performed, as there is usually an adequate leptomeningeal collateral network. This principle must be kept in mind to avoid unnecessary bypass procedures. We have routinely applied this concept in a large number of dissecting or mycotic aneurysms involving distal branches with no untoward clinical consequences, and often, as demonstrated in this case, no radiological evidence of infarct.